So now that
please tell our audience some background about yourself and what inspires you to become a psychiatrist. That's it. Psychotherapist.
Yeah.
There you go. I'm gonna get it. I'm gonna get it. Psychotherapist and other professions.
Yes. So I've always kind of had a natural curiosity of trying to understand the human psyche. So that's how we think, that's how we feel, that's also how we behave. So I started with a bachelor's degree in psychology, and of course, it's kind of just getting that generalized, broad base of understanding human psyche, human behavior. What led me down the direction of becoming a licensed marriage and family therapist is that when I was thinking about graduate school programs, I was like, what clinical setting do I want to be in? What populations do I want to work with? What type of issues do I want to help people with? And so I talked to a mentor and they said, think back on your favorite class, as an undergraduate. What was the class that you would just talk about outside of classroom? You're not doing any work. It just was natural to you. You had a natural interest. And so I actually took, I think maybe my sophomore year, I took a marriage and family class. And it was a licensed marriage and family therapist who was teaching that class. And I was like, I heard of family therapy, I heard of couples therapy, but really didn't know what was the credential to get to be able to do that. So anyways, I took that class with him. I reached out to him, kind of talked to him about kind of what his clinical experience had been and the work that he does. He was adjuncting as a professor in psychology focusing on marriage and family. But he was saying, I do run my own private practice and I do therapy with families and individuals and couples. And I also still have time to teach, so still to be able to give back in that sense, and kind of have his feet a little bit inside of academia. So that really appealed to me, as far as the kind of work that he was doing and the fact that it would give me the flexibility that if I wanted some diversity in my schedule, then I could still go back and teach at a university setting. So I kind of just modeled behind his credentials in a way. So yeah, that's what brought me where I am.
Well, that's good. That's good. Because, what I'm saying, I'm glad that we do have people, what I'm saying, that look like us that's actually doing these type of things because, what I'm
Yeah,
saying, in the time of day it is that we have people that actually need to look like who sometimes they counsel and things like that, which
correct.
goes into another thing that we have. How help us understand or help us debunk the
Mhm.
myths surrounding therapy and explain what is therapy and
Yeah,
why is it needed? Because a lot of people be like, I don't need no therapy.
correct. Yeah, a lot of people have the idea of therapy is supposed to be this magic wand, that it's going to remove your problems, it's going to undo the painful events that happen in your life. Because ideally, if we had a magic wand and if we could solve our problems in that way, then things would be fixed in that manner. But when you think about going to therapy, it's not about removing you out of the situation that you're in immediately. Sometimes that's not feasible. If you're having issues on your job, if you're having issues in a relationship, if you're having issues with family members, sometimes those are issues that you cannot remove yourself from. So what therapy does is it one gives you a place to process, so kind of unpack, take it out of your mind, out of your heart, and just instead of it weighing you down, have an opportunity to just talk to somebody about those problems and get a clinical perspective, a clinical insight on what you're experiencing and how to navigate those problems in a way that's healthy for you and also the people that are connected to you. Therapy also provides you with coping skills that you may not have been familiar with or known about prior to therapy. So a lot of times we have a tendency to navigate towards what brings us comfort and a sense of relief, but that doesn't necessarily mean that it's healthy, because a lot of times we have unhealthy vices, and they work kind of like a temporary band-aid, but in the long run a lot of times they have negative implications behind that. They bring about more subsequent issues. So what therapy does is it says we're going to give you some coping skills. Essentially, coping skills are exercises, behaviors, different ways of thinking that helps you to better manage the problem that you're struggling with, or help you to reduce the symptoms that you don't want to have, regarding depending on what the presenting issue is. and do it in a way that it doesn't create more problems.
That's cool.
Which, you know what I'm saying, Jonah, that actually goes into like the next question. It says, when it comes to stigma against people living with HIV and AIDS, can you explain what stigma is and how you have worked to eliminate the stigma?
Oh, yes. So sorry, guys. So stigma is one of those things that we cannot let up on.
Right.
We can't. Oftentimes we talk about stigma, we just hear it as stigma, right? But stigma manifests in so many different ways. And so the consequences of it, the negative consequences of it, are very powerful. So there's like 3 primary types of stigma. So we have like community stigma, general stigma, right? How people feel about HIV. You have anticipated stigma, right? So some people may not get tested because they feel like, oh, if I test positive, I'm going to be stigmatized for living with HIV, right? So that's anticipated stigma. And then we have internalized stigma, which is what I mentioned before, which is when an individual who is living with HIV feels negatively about themselves. Some have reported feeling like they have a spoiled identity or, not really worth it because they're living with HIV. And so each of these types of forms of stigma impact different phases of the HIV care and prevention continuum, right? Such as preventing individuals from taking their medicine, because if they feel negatively about themselves, they may not want to be medically adherent. Or if they haven't disclosed, they may not be able to be medically adherent because they don't want to risk an accidental disclosure by taking their meds. So addressing stigma is like one of the things where if we can address stigma properly, we can improve the disclosure outcomes. We can improve medical adherence outcomes. And so one of the things that I've done is use entertainment education once again to see how we can improve stigma. Right. So the first study that we did on the 90 Days film, we looked at it just in community. Right. It was just sampling people at the film festivals after they watched the film to see what their perceptions were about HIV stigma. So that was one way. The second way was actually addressing the population living with HIV to see how we can evaluate the film for internalized stigma, which is essentially just making people feel better about themselves, making them understand it's just a chronic illness. No need to feel bad about yourself or feel like you're spoiled or anything like that. And so through watching how entertainment education can empower, that's how I began to address stigma, specifically internalized stigma as it relates to HIV. When women felt better about themselves, they were like, I can disclose. And one young lady, I'll never forget, she called back to the center where I was partnering to do the study. And she was like, I just want to let you all know that that film and that discussion really impacted me. I want to get back in care. Like, those are things, that's music to our ears, right? I'm not in the field anymore, but that's still music to our ears when someone says, I want to get back in care. I want to be compliant because I feel empowered. So that's how I've been using my research to look at entertainment education for those 3 areas and not just look at them by themselves, right? To see overall, can it address stigma? Can it also address medical adherence? And can it also address disclosure?
For the question. So you guys are the knowledgeable people about drugs, period. Anything about a drug, me and Joe gonna go ask the pharmacist. If not a provider, the provider really, sometimes they all don't know about everything. But we're gonna come to you guys and say, hey, so can you explain what medication therapy management is and how is it used to help patients manage their medications? Because our patients come in with 20 tablets and be like, I don't know what I'm taking this for. The doctor took this off, they took that off. Then the medication's in a bubble pack and they be like, well, how do I know what it is? It's the little white pill, but I got 3. So can you explain like what medication management or medication therapy management is? And then how does it help our patients with their medicine?
Yes. So medication therapy management is kind of like a comprehensive medication and condition review. The more access we have to a patient's medication or their history, then the better the NTM would be at the end of the day. So we use whatever records we have according to the respective date to see what we need to put in what order see whatever might be going, well, not necessarily wrong, to see what may be a bit out of place as far as what a patient needs. So, you know, we just assess everything from A to Z. You know, for example, if they're on medications for HIV, we'll take a look at the CD4 counts, viral loads, those kind of things, to see how come they might not be in order if they're not. If they are on hypertensive, antihypertensive medications, we take a look at a log of their blood pressures. Same goes for cholesterol, diabetes management, even seizures. You know, like if we have an idea of, has someone been having seizures recently, we can take a look to see what the concentration of the anti-epileptic medication is in their bloodstream. So those kind of things. In a nutshell, we'll take a look at all of those, come up, ideal is having a face-to-face conversation with the patient so you can get their subjective perspective. Then you do objective, which is pretty much all the labs and everything that you have in front of you with which to work with. You assess things and then you come up with a plan as far as what you would like to do. You relay that across to the patient. If there's something that the medical or the medical provider has to take a look at, then we'll follow up with them and say, hey, you know, drug A may work better than drug B, or drug A may work better than drug B and C combined, you know, those kind of things. Just a thorough assessment, kind of like a comprehensive medication and healthcare review to see what we can do to better the lives of our patients. And during that time, a patient has an opportunity to ask, again, you know, whatever question that they have. We have an opportunity to give them a printout of what we discussed, what the future plan is going to be, what even a tentative plan might be, you know. And always important is to give a medication list to someone, kind of like what we were speaking about, and just list the indications on there, what they're used for, how many times a day they should take it. So it's a very important platform that's grown to a certain degree throughout the last few years, and it definitely has its place as far as healthcare goes. And just that platform alone is clinically oriented enough, you know, to just be able to help someone do better overall and help them understand their healthcare and, you know, what they're using their medications for, and an opportunity to correspond between the rendering pharmacist and the patient's primary care provider, or maybe even their specialist if they've been referred to see another provider.
I'm very curious. The term digital immigrant, and within
you watched my TED talk,
and within the realm of information technology, could you please explain the digital immigrant?
Yeah, absolutely. So I think the term for me comes from the space where you think of people that are natives, right? So somebody in this country is a native, right? Somebody that comes from another country is an immigrant. And the problems you have when you're an immigrant, you come into a new system, you come into a new society, you come into new norms, you got to learn things more. The same way with a digital immigrant, right? These are people that maybe never used a computer. I mean, it's funny. So I grew up in the States. When I left in 1988, it was the first original Apple, that box, right?
Yes.
And I was playing Oregon Trail on it. 3.5-inch floppy disk that you pop in, right? I went to Nigeria for years. When I came back in 2000, the internet was here. Google was coming of age, AOL, right? Hotmail. And I didn't have access to any of those things in Nigeria. And so even though I had lived here before, right, it was very, very different for me, right? And so getting used to computers, obviously I've gotten used to computers and gone way beyond that, but I had to take a pause one day some years ago and say, hey, just because you are born here or not, you may not understand technology. And so we need to treat people as digital immigrants. Now, the natives are always going to be way ahead. They're going to have like 32,000 devices. They're going to have all the stuff. They're going to know how to hack things. That's fine. But a lot of our healthcare population, especially Medicare, they're older. So they're digital immigrants. We got to treat them differently. We got to make things easier for them. It can't be complicated. It can't be on, I'm looking for paper, there's no paper here, but it can't be on a 12-page thing. And then it always used to drive me crazy that I would go to see my colleagues that are doctors, and every time I'd have to be in that damn waiting room, and you fill out your whole life on 5 pieces of paper. And I'm like, why didn't you send this to me before? You've known for a month that I had an appointment. Why didn't you email this to me? Why don't you have a portal? Right? Why am I wasting my time in this waiting room filling out paperwork that you could have given me 4 weeks before? And oh, by the way, why in God's name do you need my social on every piece of paper? And the same people will be talking to you about digital nothing secure if I have to put my social on a piece of paper. I mean, and I think that's where it's at, because think about this. Think about the amount of trust that we give people every day in hospitals and healthcare systems, because banks don't ask you for your social other than once when you open an account. One person has it, they open your account, they never ask for your social again. Right. You have a username and a password, you have a bank card, it's it. Why can't hospitals do that? Right? One time at registration, never again. Right? And actually, they don't need your social to bill. So why do they need my social? So I've stopped giving people my social probably about 5 or 6 years ago. I will not give you my social security number unless you show me a reason why you need it, especially if I have insurance. Because then my insurance information that you need, and you don't need my social. So I think that whole digital immigrant thing for me was really helping people to need to be on their terms, but at the same time enabling them to engage with the system, so it's just more advanced and more efficient.
It makes sense though. It makes, the way you explain it definitely makes sense, because you're new to this space. Exactly. we were digital immigrants just coming up in low income communities, because we really didn't utilize the internet until maybe 2007.
Yeah.
And you know, we had chat rooms. You know, when MySpace and YouTube came out and Google, that's when we really started using the internet. But it's really like as a tool in 2007.
Yeah.
And I've been able to see what you do firsthand, and you do excellent work. So for those who don't know you, can you give some background information about yourself and what made you become an advocate?
Okay, so like you'd mentioned before, I was born with HIV. I was born in Los Angeles County, California. So I was literally born out of what was one of the biggest areas affected by the epidemic. My mom received HIV from a blood transfusion. It was a very unfortunate series of events. Lost her when I was 4 years old, and that was a big motivator for me to continue doing what I do, is because I've seen what HIV leads to if not treated properly. Almost happened to me, thankfully. Thankfully, new medications came out, so it was more than just AZT, which was awful. But yeah, it's been a huge motivator, especially to stay in care, because I've seen what it's like when someone loses their life to HIV or AIDS-related complications, I should say. And it's not quick. It's very slow. It's hard to watch, and it's even harder to experience.
Right.
So, I have to say right now, because I will say this a lot to anyone out there listening that is living with HIV, get into care and stay in care. Live well, as I will say from the CDC campaign I was actually a part of.
Right.
One of my little project I signed on to. Finally, materials are out for that, by the way. There's a lovely poster of myself and my wife. My wife's actually HIV negative, so we're what we call a magnetic couple, because a serodiscordant is, one, a mouthful, and two, the word discordant can be stigmatizing in its own way.
Right.
Because goodness knows, marriage is hard enough without adding further discord to it.
Right.
So, The important message out of that is, of course, you know, you does equal you. Undetectable equals untransmittable. So because I do everything I'm supposed to do, and that's part of the whole message, you have to be in care, you have to stay in care, you have to take your medications as directed, and you have to maintain that undetectable viral load. Otherwise, you can potentially pass HIV on to other people.
Right.
I know I will ramble on because unfortunately you gave me an open section. So if there's anything specific you need to know, please stop me.
Oh, I got you.
The man told me, he was like, hey, come and be a guest on my podcast. We're going to talk about you. And I was like, great. That's my favorite subject. Let's do it. It didn't take much convincing.
Hey, it's all good.
My career in public health actually came much later. Someone who had actually been assisting me through services said, hey, we have a position open. It's for linkage, to help work with linkage to care. So when somebody either has fallen out of care or is newly diagnosed, I'm one of the people that goes to that helps talk them through the process of actually getting into care. Right. Which I can tell you, especially as someone who goes through care that knows how to navigate the system, it's almost impossible to do without help. Mm-hmm. There is a lot involved. People fall through the cracks very easily, unfortunately. So you have to stay on top of it. It's not just your case managers; it's also your responsibility. Right. I hate to say it, a lot of college students are coming into the life of HIV, and that's not easy to do when you're trying to juggle everything else. But unfortunately, they're one of our highest rated populations. So we're working really hard to try to get those people linked into care. And college students are hard to get a hold of.
Yeah.
So sometimes, like, I would end up, because I had the ability, I'd drive up like to their apartment, leave a letter, anything, like, hey, call me, I'm just trying to help you. Mm-hmm. I know it can seem a little intrusive, but it's trying to save not only his life, but the lives of future people that he may be with.
Piggyback off of that, and I appreciate you covering the services, because that was going to be the next thing we get into, what services the bond provide. But so you were able to dispel the notion that people just go here for this one thing, maybe a STD, because we know I'm from Tallahassee, so the health department on Orange, we always say was the HIV building, the one on Old Bainbridge, we always say was the STD building, but working to dispel those myths. So how were you able to fight back against those myths as the CEO of Bond and make sure people really know what the real services Bond provide?
Well, it's very hard, and I'm still working at it every day. So that's what you talked about, what CEOs do. A lot of our time, we're out bending the will of people. We're educating. We're doing podcasts such as this. We're out talking with stakeholders. We're showing what we do. We have outreach workers like the two of you, and community health workers, so that people, when we step out of the building, that our brand follows us. And so it then sparks that conversation. When our mobile unit pulls up someplace, all right, or our other support box trucks and so forth pull up someplace, it sparks that conversation. Who are they? What do they do? Oh my, you mean they have a mobile unit that has a dental chair in it and it has a primary care chair in it? So you gotta be out in the public for people to see what you do. And then you have to invite people in. So before COVID, we were inviting stakeholders, I say the word stakeholders, anybody who didn't know anything about us. We would ask people who knew about us to bring someone with them who did not know about us. And we would invite them over to actually see what we did and how we did it. And you have to sometimes do that on a one-on-one basis. Of course, we do commercials, we do talks and so forth, but it still takes a lot of convincing. And I have had to get over my little ego and not be upset when people don't know who we are and what we do. It used to irritate me, but you know, I worked to try to dispel this word. People would say, we're going to the bond clinic. I'm like, there's no such thing as a bond clinic. I don't want to be called the bond clinic until we're at the level, like you say, the Mayo Clinic. Then you can call me the bond clinic. We're the Bond Community Health Center. And within the health center is comprised of various clinics. You may have, you know, podiatry clinic or chiropractic clinic, all of this. So I spent a lot of time, and you'll hear me correct big wigs. No, it's not the Bond Clinic. It's the Bond Community Health Center. Yes. And I say it over and over and over again.
That's important, though. I'm with you. Bond Community Health Center, people.
And so, like, for the next question, it'll be more like, before we really get into the specifics about Bond Community Health Center, can you tell us about the history of Bond? Like, when was it founded? And can you tell us why, and about the history and why it was basically formed, Bond Community Health Center?
Well, it has a great history. And this is why it's so important that we continue to do well, because of those people, those founders that started this agency back in the 80s. So Bond was started by community leaders within the Bond community proper. And it actually started in one of the offices, almost the size of a closet, in the Smith-Williams Center, where you are now.
Right.
Where you have a site now. And so it started there, and these were volunteer doctors, volunteer nurses, volunteer pharmacists who generally came after they closed their office or left work during the day. They came.
When you and this is like one of my nerd moments, because I just love coming across new information and deep dive in it. And because as an outreach specialist and health educator, I try to do my best, and I ask questions in a specific way to help me understand. So when I'm giving the information to others, I can make sure I understand it and can explain it fully. And I do want to thank you for the way you are explaining this, because it helps me understand, take this information back. And I know our listeners and our viewers are definitely going to enjoy how you answer the questions and give it. And you like football too, so that's yes.
That's Joe right there, all day long, football.
So with you saying that, Mathias, another question popped in my head. We're in the world of HIV, and this may not happen, but just curious. Does the presence of viral diseases like HIV or any other diseases that a person can contract or develop over time, do those contribute to a production of breast cancer cells or anything like that? Because I know we talked about lifestyle. We'll get into this more, but can that happen?
Not so much. So most breast cancers are lifestyle, and that little bit of genetics. You know, there's some very rare types that aren't like the mainstream type things where you wonder. And, you know, but most viral related illnesses are lymphoma or leukemia, like we talked about, blood problems. Right. The other big virus is human papillomavirus, which is what, you know, people talk all the time about. We have a vaccine for that, usually in teenage years, and people are, I don't know why it's been such an issue compared to getting measles and mumps, rubella for your kiddo, you know, when they're 1. But that vaccine actually can save lives too. And because human papillomavirus, you know, you can get that and not know it from a first sexual encounter, and it doesn't have to be full, you know, it can just be skin, and then you have it for the rest of your life. And it can lead to cervical cancer, penile cancer, which no man in their life ever wants, anal cancer, and head and neck cancer. So, and sometimes completely unrelated from sexual contact. A lot of young people are getting tongue cancers and tonsil cancers from human papillomavirus. And so that's the other main one we think of. But, you know, you're right, just from a curiosity standpoint, we wonder if other cancers are related to things we encounter in the environment. Just kind of makes sense given we know those do, right?
Right. That makes me have a question. So I've known a couple of women who have breast cancer in their families, and they normally, one of my people I know, they used to have her family ran with cancer and like all different types of cancers. So she went and did a blood test to test for if she had the markers of where she could, and then she ended up having a mastectomy to go ahead like a preventative. So how does all that work? Is that something that you do as well?
It's something we work with medical geneticists. We actually have that program in Tallahassee. There aren't many programs in the state for that. You know, the universities have them, and then we have them. And so we have a geneticist in town with genetic counselors. So usually when you have those families where there's a whole bunch of cancers and you're worried about something inherited, so you can, you know, speak to the younger generation or their siblings or whatnot, you know, you try to test the person with the cancer first, right? So that's a person, if they're negative for everything you could possibly test for, then you either have something we don't know about yet, or the kid, you know, your kid or sibling doesn't need to be tested because we wouldn't find anything. I suspect what your friend and their family may have had is the BRCA gene.
Yes,
BRCA 1 and 2 are the most common breast cancer, as well as ovarian cancer genes out there. There's a whole bunch of other ones with weird acronyms and names that are like, wow, who named that, right? Some weird scientist somewhere. But those, you know, if you find that, you know, in the person with cancer, maybe a 50 or 40-year-old woman, because those often present earlier, which is kind of what I was talking about. Tell your doctor if you know your mom had breast cancer at 40, or, you know, that's a high risk population. So you would try to test the person with the cancer to see if they have that gene. And BRCA 1 and 2, those most common genes, are 50-50, whether you pass it to your kid or not. You know, it's one chromosome goes that way and one goes the other way. And so that's a pretty high risk of them getting it. So maybe the daughter, your friend there, had knew she had the BRCA from mom and got prophylactic mastectomy.
Yeah, because she actually did like blood tests and stuff because it was coming prominent in their family. And it's like every other, like I think her mom and all her aunties all had different forms of cancer, and it's just amazing how they could do that. But I just didn't know they could do that. So is there anything that people need to do? I don't know if you probably discussed it already, but like what's some preventative methods to prevent like certain breast cancers?
Well, and I'm sorry to add on, but I'm glad you asked that, but especially in this particular situation where you have somebody coming with a strong family history, what are the preventative things they should do?
And are there preventative?
But can you kind of go into a little more detail on just the day-to-day dealings with the tune-up program and just exactly how you all really go out and fulfill your mission?
Sure. Well, the tune-up program, the acronym stands for Test Up Now Education Program. So that's how we get tune-up. It is a study that's funded through the National Institutes of Health, actually the National Institute on Minority Health and Health Disparities, one of the national institutes. And so FAMU got this grant, and it runs from 2019 to 2024. At other historically Black colleges and universities and minority serving institutions around the country receive similar funding through this program to address health disparities in minority populations. So this is the larger context, and specifically the project is focused on, well, the primary objective is to test whether we can increase rates of colorectal cancer screening using the stool-based test. So you'll hear more about the different tests, the different screening modalities that are available, but we're focused on the stool-based test, the one that's typically done at home and mailed in. And we're seeing if we can increase the rate of screening completion amongst African Americans between the ages of 45 and 64 who are not current, not up to date with their colorectal cancer screening according to established recommendations for screening. So that's our target population specifically. And the way, or the what we're actually testing is a community health advisor educational intervention. So Tiffany, Miss Austin is the community health worker, community health advisor on the project. And for participants that are randomly assigned to the group to receive community health advisor education, she delivers a 6-week educational intervention, beginning with an in-person meeting, and then follow-up phone calls and text messages. And then the other group simply receives what could be called like a usual care approach. So everyone who participates receives an educational brochure that was developed by the project team in an initial phase that utilized focus groups. So we got information and verified the suitability of educational materials amongst focus group members of the same community, African Americans in that age group. And so everyone receives this educational brochure and the opportunity to complete the screening kit. So they'll receive contact from their health center about receiving the screening kit, which they can do at home and mail in. And so Tiffany deals with or interacts with one group of participants, and then we're comparing that intervention group to the other group, which serves as the control, just receives the educational brochure. So that's the primary goal of the study, is to determine the rates of screening of these two groups and compare them. Secondarily, participants complete an entrance survey, a 3-month survey, and an ending survey 9 or 12 months later, and that allows us to collect other sorts of information about their attitudes, their knowledge, and so we can compare how those may change from beginning to end, as well as between the two groups. And then another component that we're also interested in is sort of determining the cost effectiveness of this approach. So if we learn that the educational intervention that's delivered by the community health worker is in fact effective at increasing screening rates, it might be nice to describe what the cost of that would be to implement. So if a community health center like Neighborhood Medical Center, wanted to implement such a program, say hire a community health advisor, there may be some information from this study that, would inform them about, what those costs would be.
Okay.
So what is sickle cell disease? What causes sickle cell? How does it happen in the body?
Yeah, I can start off with that one, Carissa. So sickle cell disease is a genetic disorder. So the same thing that tells you what color your eyes are going to be, the same thing that tells you what color your hair is going to be, that's the same thing that tells you whether or not you're going to have sickle cell disease, sickle cell trait, or normal blood. Right. It's the body's genetic response to the malaria epidemic that happened thousands and thousands of years ago. So we were living out amongst the elements back then, constantly getting bit by mosquitoes. Mosquitoes carry that malaria parasite, and the malaria parasite lives inside of your red blood cells. Right. So people were constantly dying from malaria back, way back thousands of years ago. And so the body said, if I don't do something, pretty soon there aren't going to be any humans left, because everybody's just constantly dying from malaria. So the body decided over a extended period of time, thousands of years, they developed this trait to where some of those red blood cells were going to be in this sickle or crescent pattern, and they were going to die in 15 days. And so a normal red blood cell lasts about 115 to 120 days in the body. But these sickle cells that the body genetically created, those cells were going to die in about 15 or 20 days. And so that was going to kill that malaria parasite, and that malaria parasite will be flushed out of the body with the dead sickle cell. And so that was a good thing. That trait in that instance was a good thing. It helped humans survive that malaria epidemic. But the problems came into play is when you've got, Jack on one side of the forest walks across and meets Jill on the other side of the forest, and Jack and Jill have a child. Both of those individuals have sickle cell trait. So there's a 25% chance with every pregnancy of having a child with the actual disease when you have a child, when two people with sickle cell trait have a child. Okay. And so that's kind of how sickle cell disease came to be an issue today. People who have that genetic trait where that those sickle cells will die, and those individuals are able to survive a malaria infection a whole lot easier than somebody with normal red blood cells. And so that's, like I said, that's it. And so how it plays out today is that those two people with the trait, they'll have children. And then those two sickle cell traits, when both of those are passed down to a child, then that child can only make sickle blood. And so they've got a bunch of red blood or sickle cells that are dying every 15 to 20 days, carrying out oxygen out of the body, blocking up blood vessels, and reducing blood flow and things like that. So that's really how it plays out. And so, and one thing I do want to mention too is that most people think that sickle cell disease is a Black condition.
Right.
That it's the Black community. So the truth about that is, in our country, the highest percentage is with the African American or Black population, but behind them are people of Hispanic descent. So first in line, African Americans, behind them Hispanic descent. So it's about 1 in every 12 African Americans can have sickle cell trait. For Hispanics, it's about 1 in every 100 that have sickle cell trait. So a little bit less. And then behind people who are Black and Hispanic descent are people from Italy and Sicily. And so those people can walk through the world and present as white. You look at them, you may think, hey, that's a white person. But if they're from Italy or Sicilian descent, those individuals have sickle cell trait and sickle cell disease in their community as well. So we've got a couple of biracial families where mom is Italian or Sicilian, father is Black, and they have a child. Your mom never ever heard that they had sickle cell trait before, and they have their first kid, and this child has hemoglobin SS, the most severe form of sickle cell disease, and they're thinking, well, I'm white. How is this possible? And so that's one of the biggest misconceptions that I always like to bring to the forefront, that this has nothing to do with this specifically the Black community. It can impact everybody, anybody. There's Southeast Asian people have sickle cell disease. Just Asian folks, people of Arabian descent, Caribbean are also another population that's heavily impacted by sickle cell disease. So,
gotcha.
That brings up a good point, because my question is, like, what types of sickle cell disease are out there? Are there different various types, and how do they differ? Since you said that there was one that was a more common one, so can you just explain the different types and how many there are, and what's the difference between those?
Yeah, so sickle cell disease is the umbrella term.
Cancer in their lifetime. So during the time that breast cancer has been studied and treated, has that number of 1 in 8, is that like a progression because of the amount of breast cancer that is being found now? Or within this time of being able to find breast cancer, have you noticed that number to increase or decrease over time?
Well, it's kind of a complex question. So before the mammograms were done routinely, we were finding breast cancers at higher stages, but less in number, because there are women that have a small breast cancer that even if you never find it, they may live a normal life and never feel it. Mm-hmm. So for a women with more aggressive or bigger breast cancers, that has decreased significantly. But that certainly does mean that we are catching somebody at the age of, say, 75, a small breast cancer that she may never have known and may have lived normal life without ever knowing about it. So there's the pros and cons of, saving the women who would have died from breast cancer. That number has significantly gone down. But there is a little truth to that the number of women diagnosed with breast cancer has gone up since we were doing the mammogram. So we're catching them more. And there is certain women that may not ever need the mammogram, but it's very hard to tell in the community who is okay not to be screened and who does. So there is certainly increase in number of mammograms. So there's increase in number of breast cancers that we have seen.
Okay. All right. That makes sense.
So, breast cancer, currently, if the breast cancer is caught in an early stage, like a stage 1, even a stage 2 breast cancer, what it usually means, so different stages of breast cancer is depending on the size of the tumor, whether the cancer has spread to any parts of the body, whether it has spread to the lymph nodes or not. So most commonly, we are catching breast cancers at stage 1, early stages. So those women, after all the appropriate treatments, have an excellent outcomes, and more than 90% of them live a normal life, 10 years or longer, breast cancer free. So, different stages of breast cancer, catching them early also means we can assure them that there is a very good chance that they're going to be breast cancer free and living 10, 20 years, or maybe even a normal lifetime, and something else may get them, but not breast cancer. And so that's kind of with the staging of breast cancer. So a lot of women ask us about, they have breast cancer, can they get it again? So most certainly, actually, some women who have one breast cancer are still at an increased risk for a future breast cancer. So even having one breast cancer surgery does not mean they stop their mammograms. We recommend they continue to do their mammogram even more diligently. So, year after year, year after year. And definitely letting their family members, their daughters, sisters, also know if they had breast cancer. It's a good thing to share with the family members. People are scared because, again, there is a stigma. So I do want to take that myth out that all breast cancers are going to be bad and they're going to cause a big scar, or women will always remember that most of our women with early cancers, they forget they ever had cancer. 5 years later, 10 years later, it's in the back of their mind. I'm sure they never forget something like that happening to them, but they go on to live on their normal business and, back to being functional members in the society. And places like you guys as a neighborhood medical center, a Bond clinic, even the Department of Health, they're crucial in encouraging those women to get their screening done, get their testing done. I want to thank you guys and the neighborhood medical center who brings up a lot of women who are otherwise underprivileged. And
you had a chance to sit down with any male that you can pick that you have a great relationship with, and you have a chance to give this male dental information and dental advice. So how often would you tell this man to go to the dentist, and what questions would you prepare him, or you would get him in the mindset of asking his dentist to make sure he get the healthiest result from his dentist visit?
Well, first I'd probably tell him to come see me.
yeah, exactly.
Okay, I need you to come see me more often. Okay, and we're joking around, but as often as you need. You know what I mean? And the reason I say it that way is because, I think commonly we're locked into, you go to see the doctor twice a year. I get cleanings every 6 months. Okay. But what I don't think is widely understood is treatment includes cleanings. Like, cleanings aren't necessarily something that we can kind of just do arbitrarily. They have to be diagnosed. That those type of 6 months cleanings are directly correlated to a diagnosis. Right. So if you fall into, if you are diagnosed with such a disease, commonly just gingivitis, things that we can essentially reverse, then okay. But that had to be determined, because if you're not a candidate for that type of a cleaning and you need something different, say scaling and root planing, that has to be determined, and then the type of interval that you would use maybe more often.
Right.
Okay. And what's funny is that common interval was not developed by dentistry. That 6 month interval was actually developed by insurance companies, because they're going to be the ones to pay every 6 months.
Right.
So therefore we kind of fall into this, I go every 6 months. Okay. But how often you go to the dentist, specifically for, hygiene treatment, that has to do with what you need. So you may have to come every 4 months. You may have to come every 3 months. So that has to be diagnosed.
Right. Okay. That makes sense. But okay, you just blew my mind. Didn't know about the insurance part. Like, I'm learning more and more about these insurance companies, and I'm side-eyeing all insurance.
I don't want to demonize the insurance companies, man. We just have to conceptualize what they're really there for. You know, I tell my patients all the time, dental insurance is a coupon.
Right. Yes.
It could be a $50 off coupon. It could be a $5 off coupon. But it's essentially a coupon, you know?
Yeah.
And you don't want to fall into the mode of thinking the dental, like what my dental insurance covers is what I'm going to get.
Right.
Okay. Now there's nothing wrong with making treatment decisions based on, you know, what's feasible.
Mm-hmm.
There's nothing wrong with that.
Right.
But you have to keep your mind open that there is a treatment for a diagnosed problem, and this is what I need.
Right.
And my insurance company is the coupon.
Well, I'm just going to leave it to you as to where to start off in reference to discussing sexually transmitted diseases and women.
Okay. Well, that is a very vast area, as one can imagine. I will start with some of the more common sexually transmitted infections that I see on a regular basis within the clinic, within the population that I service, as well as that the population is more aware of. So just to start in no particular order, and feel free to jump in at any time, Mrs. Steeple. Okay. But I'll start off with chlamydia, as that is one of the most common sexually transmitted infections in the United States.
Now, is that from when you see them young until, you know, I mean, do you see more in the young than the old, or how does that?
It's really respective of the population. When you look at it in terms of women's health screening, yes, they do recommend that annually up until age 25, once a person becomes sexually active, that we should be assessing for chlamydial infection. However, in certain populations, with it being so prevalent, you want to continue to test annually. And that is something that in pregnant women, we're going to screen for that regardless of risk. Okay. Because with chlamydial infections, it's one of those sexually transmitted infections that may not have any symptoms whatsoever.
Wow. Can you elaborate on that a little bit
more?
Oh.
Absolutely. So there are sometimes symptoms associated with chlamydial infections. That could be some spotting after intercourse. It could be some discharge. It could be some odor that you notice there. However, sometimes there may not be any symptoms. So you may not have any discharge. You may not have any spotting after intercourse. You may notice nothing abnormal. However, when you come in for an assessment, your provider, when they assess you, they may notice some mucopurulent or some pus mixed with some white blood cells on your cervix. They may notice that your cervix may bleed easily when they are assessing it, or it may just come up incidentally on testing alone. And now, many times, go ahead.
I'm sorry, is there any pain associated with a chlamydia infection?
There may be some pain there, and most women will report some pain with urination. Okay. For men, they may have some different symptoms as well, some pain and some discharge from the penis. Okay. So there may definitely be some pain associated with it. That's correct.
Ah, interesting. Mm-hmm. So really, do you know how long it takes for those symptoms to possibly?
Mother's taking care of her health. Wouldn't she also try to teach the son to do the same thing and try to get him to go to the doctor? But you still people try to put men in a box.
Yeah, exactly.
And it's only a certain way you can be. You got to be this macho, masculine man, and that's it. You can't cry. You can't show weakness. You can't show pain. But that's not every man. There are some men who are more feminine outside that's not in the LGBTQ community, but they're just more softer than others. That's what I like about a lot of TV right now. Like some of these series, they're showing different sides of men that are still manly men, but they're not as masculine. They're not as, you know what I'm saying? In some people's minds, you get that image of this is what a man is supposed to be. and it's wrong. And like you put in a stereotype about how women are supposed to be, but it's stop putting people in boxes and labeling them, and let these people or the new generation be who they want to be.
But you know what though?
That's
thinking about. Okay, and I once again I use my own experience. My mom go to the doctor a lot. She goes to the doctor, but growing up, for me and my brother, it really wasn't, even though we saw her going to the doctor, it wasn't stressed, or it wasn't like the thing to go to the doctor as a man, because she going to the doctor, in our mind, she was going to the doctor for women's issues. And women got, and it was the perception was women had more issues to go to the doctor for, to make sure they keep stuff up. But after the conversation with my dad, though, that actually made me go to the doctor.
Ah, interesting.
And so, but that goes back to what Mathias is saying, the influences within the home, because it's important for a young boy to see a grown man being a healthy grown man. So I can emulate those things. Because yes, I can see my mom doing that, but that's moms.
That's right.
But and it doesn't even have to be a father figure. It could be an older brother. It could be a cousin, someone he looks up to, because we do understand that there are some single family households out there. There's going to be some fathers in and out there. There's going to be some people that say, I don't even have a father. You know what I'm saying? Or their fathers are deceased or whatever. But you're in a single family home. It still needs to be somebody else in your family that needs to step up and say, hey, how come you're not going to the doctor? Or, you know what I'm saying? Once you get those, I think in school, once you get those shots, and that's it after that, it's like it's over, it's over. I need these shots to go to school, so while I get the shots, I get my physical, I get everything I need.
But that's real though. But that's real, because it go back to what you were saying earlier. It's like outside of yearly physicals or something like that, if nothing's hurting, we're not going.
Right.
We really,
and we're not telling everybody got to go to the doctor every month. We're talking at least twice a year.
That's why the insurance industry they love young males.
Yeah, because we're paying for the insurance and we're not utilizing the service.
And you're not using it. Yes, that's exactly right. That's why they were, when the Affordable Care Act first came out, they were like, oh yeah, we'll get the young, healthy males to pay for that sick pool. The mature people who are not quite Medicare age, but they're sitting somewhere in the you guys are what the insurance company look for, those young, healthy males.
But no, I'm glad you said that. I'm glad you said that, because that's important for young men and people, period, to understand. It's you sitting up there feeding the pig and not even using the services. That don't make sense.
That's right. That's right.
And I did it for a while. You telling us that there are a number of women in Tallahassee who are pregnant or may have babies, but don't know where to turn to get maternal and perinatal services right now.
Yeah, so there are, home visiting programs. There's Healthy Families, there is Healthy Start,
right.
There's WIC at the health department. So yes, all of those programs are great, right? And then we have the women that are going to their OB appointments. So of course, it would be ideal that these clients would talk to their OB and their OB would answer all of their questions. But in the real world, does that often happen? Does a client really have a chance to ask all the questions that she needs to ask? Does a doctor really have time to really go over, like, okay, you're in your second trimester, this is what you're going to be expecting, and this is what you have to look forward to, and those type of things. And so I think, so for sure, like with childbirth education, I would say women don't know that they need it as much as they do, because so much information is given, but because most of the time it comes with a cost, then that's like out of sight, out of mind. And so.
Right. Okay. Yeah. Okay, I got you. So you kind of hinted on it, that you want to be able to provide services for women or families that may not have had those services. But so, because it's like, what was the tipping point though for you? Because I know you see it. We all see it. We all grow up seeing it. But what was that tipping point that you was like, I can't take this no more? Not only you was like, I can't take this no more. Let me get into these services. Let me learn what I can. Let me become a part of this. Like, what was that point?
That's a good question. I would say just over time working with women. I've had, countless of clients that would be going to see a maternal fetal medicine. And when I ask them why, they don't know. I've had clients that, had a C-section. When I asked them, okay, so why did you have a C-section? I don't know. They just said that I needed to have one. I actually know someone, when I was teaching childbirth classes at the health department, she had 2 C-sections and she was pregnant with her 3rd baby. And she was like, no, I want to have a VBAC, which is a vaginal birth after cesarean section. The first time she got her C-section, she was young. It wasn't necessarily needed, but, she didn't know. So she went on with what the doctor said. And then, of course, after you get your first C-section, the doctors, recommend that you continue to get them. And so with her 3rd baby, she was like, yeah, that's a no. Like, I want to try to have a vaginal. And she did. She attended my childbirth class, and her baby now is 8-9 years old, had a successful vaginal birth after cesarean. So I would just say over time, it's just been an accumulation of different things, different scenarios, different clients that I've worked with that has gotten me now. So, yeah.
Gotcha. Because there's always that point or that one thing that makes people say, you know what, I'm not taking this no more. I can't sit around and watch this anymore.
Right.
Okay. So interesting about this show today is, what's one of the things that people usually do health-wise at the beginning of the year? Every year.
Work out. I got to get my gym membership.
Right. Now, before you work out and before you get your gym membership, you should be doing what? Setting what?
Goals.
Right.
But you need to set achievable goals, not just the goal.
Right.
That's what people go wrong with, Joe. You
right.
set that goal and be like, I got a goal. But you ain't set that achievable goal.
That's right. And losing 50 pounds in 1 month is not an achievable goal.
Right.
It's not. Let's just call a spade a spade.
Now, Miss Steeple, that might be a good goal, though, if it could really happen. But then I'll be already something about it fine instead of being where I needed to be at summertime.
That's right.
So today we're focusing on setting smart health goals for the 2021.
That's right.
All right. So remember, SMART stands for specific, measurable, attainable, realistic, and timely.
Look at you.
I knew that.
I knew it. One thing, your first goal, and this is coming from me as a provider, should be to have, before you start any exercise program, is to visit with your provider.
Yeah.
You don't want to start something that is going to challenge you, right? Without first talking to your healthcare provider. That's the first thing. Make that your first goal. The goal is what? To visit my healthcare provider.
So you telling me at the beginning of the year, we supposed to be jam-packed busy with people trying to get themselves together and get right?
Well,
to the gym.
So we need to call these patients and be like, hey, we ain't seen you since last year. Where you at?
That's right.
I know I seen you December 31st, but it was last year. That's what the patient told me this morning, Miss People.
What'd they tell you?
Wish I would have known that when I was in school.
Right. I ain't utilized my services, Joe, but now I wish I would have did. I would have knew these women earlier, and I would have been better.
I'm going back. All right, so you got the first question, Mathias. Let's kick this thing off.
So my question is, can you ladies tell us
some background information about yourselves, and tell us the positions that you hold at Student Health Services. Because I know that y'all wear many hats. So can you just narrow it down to what you ladies do at Florida A&M University Health Center?
Well, we do a little of everything. And first of all, I just want to say I love you guys. I love you guys, and I am very happy to be doing this.
Thank you.
Thank you. We love you too.
Okay, I am Evelina Balkman, and I am in charge of I'm the volunteer coordinator. I am also the food pantry lady. I am also our farm share second harvest distributor, and you all want to know that.
Yes.
And I'm everything else that Tanya Tatum wants. So what I do is, if there's a student that's in need of our services as far as food, they just come to the clinic and ask for me, and I'll pack them this big bag of groceries.
Yes.
And even toiletries. And we'll provide them with it. And you cannot come too many times.
Right.
There's not a first or a second. Just when you're in need, you can come and see me, and I will assist you. Okay. As far as volunteering, many students need volunteer hours in order to graduate. So, and if you come and assist in the health clinic, whatever amount of hours you provide, we'll give you those hours, and at the end of the semester, total them up, give them to the student, and they can have them put on their transcript.
Oh,
yes.
Okay. Harriet? Now, what kind of food is located in the bag? I mean, are we just looking at canned goods? Obviously non-perishable, but I mean, are there other things that are in there, such as like juices or, you know, what kind of nutritional food? Because students are already eating poorly. So what is the Student Health Services passing on to them?
Okay. We also provide food from the Tallahassee Co-op, the organic food, and it consists of yogurt, eggs, butter, milk, meat, snacks,
fruit.
Okay. Fruit.
Okay.
Right. It consists of everything that they have.
Okay.
And students love it because it costs so much out of the store. And with us having it, it gives them a chance to eat a lot of what they cannot afford to eat.
Right.
If they had to buy it on their own.
That's good. That's good to know. So if you have heard students that the food is not of a nutritional makeup, that is not correct. That is not correct.
They get healthy food.
They provide nutritional, good, solid food for you to have a good meal so that you can go to class and learn what you have to learn. So
there you go.
Exactly.
Now, question, Ms. B, is it, if I'm passing through the neighborhood and I know I need food, am I able to stop through at some of the farm shares and things like that, or is it just to FAMU students?
Well, it's available to everyone that's in need. Only thing is, if you're in the neighborhood, you need to call me and make an appointment. Because now you cannot just walk in due to COVID. So you would just need to make an appointment and come through, have your mask on, put your trunk up, and I'll serve you.
Okay, that's perfect. Y'all hear that now?
So
they give them good food.
So let's